Well, thanks very much for the invite. I'm sorry I can't be there in person. I'm actually staying on a farm today, so there are a few chickens in the background. If you're wondering, you're not going mad. That probably is chickens that you hear. I've been asked to give a talk related to the UK PHEM training process, having completed that before I came to work with the team here at Sydney Hems. So this presentation, I'll start off with a few disclaimers and a few sort of caveats, and then we'll look at like a whistle-stop tour of what PHEM looks like in the UK, and then focus on the subspecialty PHEM training and assessment process. Now I'll finish with my sort of three main lessons on my sort of pre-hospital journey so far. Before we go anywhere though, I just need to clear up a little bit of UK lingo that I'm going to be flicking back and forth with. Whenever I did one of my sims during Sydney Hems induction, I got about 8 people looking blankly at me because I said I was from the air ambulance. It turns out that isn't an international term. So in the UK, the umbrella term for all pre-hospital care is pre-hospital care, and that includes first aiders at events, ambulance services, enhanced care teams, which may or may not be a physician, may or may not be a helicopter model. Air ambulance is technically just the transport platform, and there are obviously non-emergency air ambulances, essentially charter flights. However, the charities in the UK have adopted that term as it is well understood by the public. So many, not all, but many of the air ambulance charities in the UK call themselves, like Air Ambulance Charity Kent, Surrey, Sussex, Northern Ireland Air Ambulance, for instance. And they're sort of more than an air ambulance because they're helicopters with blue lights on them, and they can land at HEMS sites. And so HEMS, Helicopter Emergency Medical Services, is part of air ambulance. But in the UK, we still use air ambulance quite broadly because of the charity association. And then separately from the modality of transport, there's this thing called PHEM, which is obviously a slightly different combination of letters from the Australia and New Zealand terminology of PHARM, pre-hospital and retrieval medicine, and PHEM stands for pre-hospital emergency medicine, and that's the sort of designated name for the subspecialty area. And you can have PHEM accreditation, as we'll get into, but you can also work in the area of delivering PHEM, not necessarily with the certain levels of accreditation, and I'll explain that as we go. But the subspecialty area of PHEM that I've been talking about there is probably not new anymore. It's in its 13th year in, I think, this month or next month. So it's about a 13-year-old subspecialty area in the UK. I said I was going to give you a few disclaimers, and I appreciate this is 6 photos, but everybody's journey in pre-hospital medicine, and I think this is international, is different depending on your background, what you've done to get to where you are today, and that skews my view of the whole thing, and it does introduce a little bit of bias. So I'll walk you through what I've done, and then hopefully everything I say from this point you will take with a pinch of salt, or understand that I have a little bit of bias in how I'm describing things potentially. So as most of you will know, who are in the team there, I did my emergency medicine training in Northern Ireland, and that's one of the buildings in the top left there is the Royal Victoria Hospital, which is Northern Ireland's major trauma centre. Not all the EDs in Northern Ireland look like that, obviously. My first exposure to pre-hospital care in the region was with Mountain Rescue, voluntary role. Then I did a year full-time PHEM training in the southeast of England with Kent, Surrey, Sussex. And then I returned to this building to 5th and 6th floor to do a post-training fellowship in intensive care medicine. And alongside that, worked with NISTAR, Northern Ireland's specialist transport and retrieval team, which is ground-based only transfers of level 2, level 3 patients, so ventilated adult only. And I did a few missions with a outfit called 247 Aviation and a Learjet. That was international work across Europe, before coming to yourselves at Sydney Hems. So focusing then with that sort of bias out of the way on the provision of pre-hospital HEMS services in the UK. This is a summary of all the charities, and most of them are charity funded, at least in part. There is different levels of government funding and different agreements with different charities. And one thing to point out in particular is in Scotland, there's an outfit called Scotstar who do a lot of the transfers out to the islands, and they have fixed wing as well as rotary aircraft similar to ourselves at Sydney. And they're more government funded commissions for those transfers, and therefore they don't appear on this charity map, but they are present, main base being Glasgow. In terms of the provision of services, so if I flick between these two maps, you can see the number of red dots, and then if you can imagine those red dots are now on this green map, you can see for the geographical area there is many more helicopter bases per sort of square kilometer. And you can see some statistics which I'll not read through on the left, but the long story short is in England you're providing services for a denser population, and alongside that the mission cycles are often shorter because there's a shorter geographical area, and in some areas that might actually increase the chance of you conveying by ground vehicle even if you dispatched by helicopter. The most notable example of that is London, who ground escort the majority of their patients. The work, though, is very similar to Sydney Hems, as you'd expect. It's working with teams, flash teams, not just of ambulance personnel, but police, fire and rescue, to achieve safe, reliable outcomes for patients. And that extends to working in complex and at times major incidents. And this slide as well, there's a lot of text, I appreciate, but there's nothing groundbreaking here. It's exactly the same stuff for the primary missions, which is the bulk of HEMS work in the UK. Trauma patients, for the most part, depending on the service that you're in, will dictate how many cardiac arrests that the service attends. And people will be familiar that certain services are exploring the role of endovascular resuscitation techniques, including ECPR. And so if the service is involved with that, then the proportion of patients in the medical sphere they attend will be higher. But there's nothing really on this slide that's different from Sydney Hems, but that is the primary work. And I put complex incidents in there. That includes major incidents, and a lot of charities, for example, Kent, Surrey, Sussex, the only thing they are commissioned for is the provision of like a merit role, a supplement of a physician and critical care paramedic to the major incident response. Everything else they do is primarily charity funded. So if we look at breadth of clinical activity, this slide's intentionally poorly labeled, so I have to talk you through it because it's just an estimate. It's not based on any specific figures. But if we look at if we look at the whole field of pre-hospital care, the red, let's say, is primary missions. The purple is secondaries or inter-hospital transfers, and the blue we'll say is rescue missions, which at Sydney Hems obviously includes the water rescues and remote access stuff. So most Hems charities in the UK operate almost always in this red zone, never in the blue zone, other than landing in a remote field, arguably. And then sometimes encroach in the purple zone to do what are called hot transfers, so like time critical subdurals who've been stabilized in a distant trauma unit that need transferred for urgent neurosurgery. Generally speaking, the purple area here, the secondaries inter-hospital transfers are conducted by separate groups. For example, in London, the relatively new sort of pan-London group is called Access, and they conduct all the inter-hospital transfers, say, of ICU patients. And I just thought I'd put this here for a second, and I know we all know this, but we mustn't forget that everything we're talking about here is actually a very small component of pre-hospital care, and the bulk of it is done by ambulance personnel, be it paramedics or otherwise. And it is part of our role in the UK and in Sydney to empower that group, whether it be through engaging with teaching, debriefs, or just working with them constructively at scenes so that they can deliver, as I say, the bulk of pre-hospital emergency care. So looking at this blue component, who does that in the UK, given it's not really covered by HEMS like it is with Sydney HEMS? For the last 10 years or so, Bristol helicopters have had the contracts that follow the government process, which took it intentionally away from the military. It was previously the Navy and the Air Force that did it. And so the only winching SAR asset in the UK is the Coast Guard, and they have advanced paramedics, which is this chap in the middle, on board one of. Just a nod, though, that there is a very well-established MACA process in the UK, military aid to civil authorities. So obviously some military assets have winching or certainly aircraft abilities, and they have been used in that 10-year period to help in times of flood, etc. If we then talk about the transfer services, I've mentioned teams like Access and stuff. In a typical PHEM service, unless it's exploring ECPR, there will be no transfers on ECMO, balloon pump, or Impella. For the most part, that is reserved for specialist transfer services. The picture on the right is, as you can probably tell, a pre-hospital mission, and the reason I put that up is, although HEMS services don't cover transfers, I would put to you that nearly every primary mission has a component of transfer, and sometimes that's the sickest patients. Obviously, there's additional complexities with retrieving sick patients from remote units, and there's a lot more involved sometimes in terms of the periphery. But I don't think it's right to say that HEM services in the UK never transfer patients. Actually, every patient, or a lot of patients, are transferred. I meant to put a photo in here. I just realized I forgot. In terms of that provision of services, then, unlike Sydney HEMS, most charity air ambulances for their road response are in rapid response vehicles, like Volvo XC90s or similar. And so they don't have conveying resources. They'll use the local ambulance service wagon. Next slide is a snapshot from HEMS Base about the work that I did in my 1-year PHEM training with KSS to give you an understanding of the job distribution. So you can see there on the left the total number of shifts, intubations, blood patients, and I'm not entirely sure how it will look on your screen in the lecture room, but you can see there the distribution of cases. It looks like most medical, but that's because the trauma patients are split. So it is still a majority of trauma patients, and you can see there the largest proportion conveyed was by ground, but I think that's about 54 by air. So that's just to give a rough indication of, if you were to work for a year in a UK HEM service, roughly the distribution of patients you'll see. And Obviously, similar age distribution to the patients we see here in terms of young males, but we see elderly patients and neonates and infants too. So if you were in the UK or looking to go to the UK to do a HEMS career, what are the options to work on a helicopter service? And from my point of view, I feel there's three routes. You can do a fellowship locally by applying directly to one of the air ambulance charities, and they're often 12-month posts and often includes pretty extensive local induction processes, and you're involved with clinical governance activity in a similar way to Sydney HEMS does. The second route is to do a fellowship abroad, and there are a number of people, for example, in Northern Ireland and Kent, Surrey, Sussex, who have come to Sydney to do some time here and then have gone back there. And that cross-pollination of experience, I think, is really useful to generate different ways to deal with problems in an organization, if nothing else. And then the third route, which is increasingly popular, I would say, and increasingly well recognized, is the formal PHEM subspecialty training route, which I've introduced already to you. It's about 13 years old, that process. And the next part of this talk is going to talk about what that formal training pathway looks like. So to do it, you need to be a registrar in either emergency medicine, anesthetics, or intensive care medicine. Most are either emergency medicine or anesthetic trainees. And you can see there how it integrates into the program. Generally, you have to have completed at least one registrar year, and then it's competitive recruitment. So from after 1 year of registrar training, you can apply each year to get onto the program, and that includes the year post training, so like a final year of training. And that whole process is governed by a group called PHEM, the Intercollegiate Board for Training in Pre-Hospital Emergency Medicine. And that is formed from the three colleges of those specialities I just mentioned. So the Royal College of Emergency Medicine, Royal College of Anaesthetics, and the Intensive Care Medicine faculty. And the PHEM issue this curriculum, which is summarized in the diagram, as you can see on the right there. They're on their third version in 2022 of this curriculum. I'll link to it at the end, but essentially the General Medical Council, which is the UK's version of AFRA, issued sort of generic professional capabilities framework upon which all specialty and subspecialty training programs need to be based. So that's what the general professional capabilities thing in the middle alludes to. And if you looked at 2 or 3 curriculums now in the UK of different specialities, they would all have similar cross-cutting themes. But on the outside is sort of the pre-hospital specific stuff. And these are obviously the overarching headings. I'll not read through them, I'll let you do that yourself, but it covers all the equipment, attitudes, behaviors, skills, knowledge for primary jobs, as well as patient transfer from pediatrics to comorbid and elderly and major incident stuff, including CBRN, for instance. So how does this training program support the trainees in achieving a coverage of that curriculum? The first thing is a week-long national PHEM induction course where PHEM trainees from across the UK come together. It's held, at least to date, on the ATAC or ATTAC course centre, which is a fire and rescue training centre in Lincolnshire. and they have a number of things like closed roads that they can simulate MVAs on collapsed buildings that are actually stable, so you can train safely in them, etc. And they get sort of police support and some local drama students, etc. at times to add some fidelity to scenarios. And the nice thing is, even from that 1 week course, you start to get portfolio tickets completed to evidence your learning. And as we'll come to, the curriculum is quite large to cover. So it's good to get certain things covered off early on. Other courses through the year then include dedicated transfer training courses, which is important because, as I mentioned, there isn't as much of a focus in most UK services, Scott excluding, on that transfer aspect. And another one that's sort of nationally coordinated is the PHEM obstetrics course, PHEM OBS, in Nottingham, and it's pretty good because obviously we don't see the pre-hospital obstetric emergencies even as often as paramedics on the road do in terms of deliveries, etc. So the training is 12 months full-time equivalent. 1 month is 100% supervision, so called phase 1A. The next 5 months is 50% consultant supervision. And then in phase 2, it's 20% consultant supervision. And you might think that is quite a lot of supervision, and it is, and it's actually increased with the 2022 curriculum since I completed my training to those figures. And that's to make sure that trainees have the opportunity, especially early on, to grow into the role and to evidence their learning against the curriculum by having a consultant supervisor with them that can complete their portfolio assessments. Talking of which, at the end of the training year, which may be, by the way, a full-time year or split, so 6 months parent speciality, 6 months PHEM, and then another year of the same, the 1 year or a sort of blended program. Regardless, it's 1 year full-time equivalent. And in that time, then you have to evidence the entire curriculum. And at the end, there's this thing called a TAP, Trainee Assessment Panel, who look for all the evidence, which you can see listed there. To do that, you need to complete a logbook. A lot of services use HemSpace, so you can click a couple of buttons and it will draw your personal logbook from the patient records. So say you've done a thoracostomy on a patient and an RSI and a warming blanket. Then at the end of the year, you'll see how many thoracostomies, RSIs, and warming blankets you've put on at the click of a button, which is quite nice. Although nationally, there's also this thing for trainees called PHEMnet, which is a slightly less user-friendly software than HemSpace, but it does allow you to log each of your patients, each of your interventions, to maintain or to keep a record of what you need to keep a record of. Every 6 months, you need to do a multi-source feedback. So all the critical care paramedics, doctors you work with will give feedback on your performance. And then there's each 6 months a faculty educational governance statement, which is obviously the trainers in the organization given they often use the MSF to feed into that, as you can imagine, but they provide pointers and essentially a recommendation about whether or not you can progress or need remedial stuff. And so again, going back to my year, what this looked like was, in terms of portfolio, 48 reflections and 154 workplace-based assessments split into shift observations, DOPS, KEXs, SIMs, CBDs, and training observations. To be fair, 50 or so of those would have been SIMs from the induction course and PHEM OBS course, but still quite a lot of portfolio burden. which was challenging to complete, it must be said. Although with the 2022 curriculum revision, there is a slightly lower burden in terms of volume of assessments, but you do need at least 10 observed shifts per 6 months, and you do still need to cover the entire curriculum. In terms of then formal assessment, because what we've talked about so far is supervision, and we've talked about curriculum coverage and demonstrating you've done that. There's obviously the examinations as well. And the reason I put this, this is a UK-wide Skills for Health framework. The reason I put this up first is the exams are targeted at certain levels on this framework, not necessarily just for the trainees. So the diploma in immediate medical care is targeted at level 6, and the fellowship in immediate medical care is targeted at level 8, or for doctors that is a consultant level practitioner typically. So I just wanted to highlight, to do the pre-hospital examinations in the UK, you absolutely do not just need to be a doctor, and you don't also need to be doing the formal PHEM training program. I would say the formal training program is the most straightforward in terms of logistics to make it work, because you have the portfolio evidence, the opportunities with those courses I mentioned, the supervision time to show that you're eligible for the exam automatically. Whereas if you elect to do it as a fellow of a service and accumulate the evidence yourself, you then need to get all that paperwork together essentially and apply for, as you can see in the slide there, this certificate of FIMC eligibility to allow you to sit the exam. Essentially, you have to prove that you're operating at that level 8 level. And if you're a nurse or a paramedic working in the pre-hospital sphere, you can still apply to do that. And the first paramedic sat and was successful in his fellowship exam in 2022, and subsequently became a consultant paramedic, I believe, for Thames Valley Air Ambulance. So anyone can sit the exams. And for the fellowship, it's still mostly doctors. For the diploma, there is a substantial number of paramedics who do it, especially those who are pursuing critical care paramedic roles, which is similar to the intensive care paramedic roles in Sydney. So this is the format of the exams. For those of you who don't know, the writtens are 3 hours long, single best answer questions. The diploma is a 1-day practical with 12 8-minute stations and 2 60-minute stations, and that'll be at that level 6 standard, but with a pre-hospital focus and a fair bit of solo responder stuff. So you'll have to do like ALS on your own for a time. It includes things like neonatal resus, etc. The fellowship exam has got the written, but also 2 days worth of practical exams. Still 12 8-minute stations on day 1, and then on the second day there are 2 24-minute sim stations, which are usually quite high fidelity. So they were fun in a slightly twisted way, but definitely quite challenging. And in terms of pass rates, the diploma level exam has a higher pass rate, being targeted at that lower level. It's got a pass rate of about 82% in the 10 years up to 2021, which is the last sort of published bulk results. The fellowship exam, as I mentioned, is quite challenging, and its pass rate up to 2021 was 53%, which is quite low, especially considering you need to prove you're already operating at the level of a level 8 clinician before you sit it. And in the past couple of years, there's been a little bit of effort to help prepare candidates more specifically for the format of the exam. So we'll see what happens in that regard. So that's a run through of PHEM in the UK, the PHEM training, and the assessment process. Next couple of slides are just my lessons that I've learned along that way, and then I'd be very keen to answer any questions that may have arisen from what I've spoken about. So first big lesson for me definitely is that systems and the culture that drives those systems is much more powerful than an individual. And that was something I learned probably most clearly with in my first sort of 6 months at KSS. And it was quite humbling. I mean, I try never to think that I can do everything anyway. I'm not that sort of a person. But definitely the system at KSS and then subsequently Sydney, and also to some extent the other services I've worked in, Mountain Rescue, NISTAR, those are what makes things safe for patients and makes outcomes reliable, not individual performance. And on a similar vein, I've learned in that time, in my pre-hospital time, more so than in my in-hospital time, I would say, the importance of reflective professional activity, whether or not it's recorded in a written portfolio, reflecting on how you did that last job, how you interacted with the teams, into yourself, ideally with the person you were with, be it the nurse or CCP, is extremely powerful. And I hope that I have developed over the last sort of 4 years I've been involved in pre-hospital care, in large part due to that. And this concept of marginal gains you'll all be familiar with. I think that's very important. And I would say when you're going to the same patient presentation, bumped head RSI, shall we say, again and again, literally multiple times per week, it is potentially easier to work on those marginal gains. And if you don't have that frequency of the same patient presentation, then shared learning becomes even more important. And that's something that I think Sydney HEMS does particularly well, in terms of each of us don't do that many RSIs per year compared with other international services. But yet, as an organization, we still feel like we're working towards these marginal gains. And I think that's fascinating, that with a different frequency of clinical activity, you can still be developing along those lines. And finally, I like to include this slide anytime I talk about pre-hospital care, because in the first half of my medical career, I was very driven towards the next thing, get on to emergency medicine training, then get on to pre-hospital training, do this exam, do that exam. And I think I lost sight along those along that time of enjoying each moment, enjoying where you are. In terms of pre-hospital care, it's an absolute privilege to do the job, to provide care for people in their time of needs, to bring comfort to those in distress. And I think we do that at a higher frequency often in the pre-hospital environment than the in-hospital environment, it could be argued. But I always will recommend to people who are pursuing this career path after me to enjoy each moment along the way and make the most out of it. So my last slide, just to leave up for discussion and questions, hopefully there will be a few, is links to the IBT PHEM website on the left, which is where the full curriculum document can be found, and how you can apply for UK PHEM training. You can apply from outside the UK, but you need a training number in EM anesthetics or ICM first. So you need to apply internationally to get onto those training programs before you can apply to get onto the pre-hospital one. but it is possible, and all that info is on their website. And on the right is the Faculty of Pre-Hospital Care's website. They're hosted by the Royal College of Surgeons of Edinburgh, and they coordinate mainly the exams, and related to this presentation, those exams, as we talked about, are the DIMC and FIMC, and they're absolutely open to international candidates. But if you just want to learn more about the examinations, all the regulations, etc., are on that website. Thanks very much. I think we've got up to 7 minutes for questions and discussion.
Well, thanks to Richard. And massive thanks for doing it from your holiday. Hope you're having a great holiday. A couple of questions I had.
So good.
One was there's lots of photos of people in kind of orange outfits who I can only presume are council workers on scene. Where are the doctors and paramedics?
To be fair, KSS has recently changed its uniform back to a slightly more traditional red colour, although that orange was argued to be red throughout its lifespan. I never fully agreed with that, but yeah. It's nice when you stop at a petrol station, though, and you can go in for a coffee and no one troubles you because everyone just thinks you work for the council. So that's good.
Cool. I guess the interesting thing, in Australia, we were a bit slower in starting the version of the intercollegiate board for training, and we quite actively included retrieval medicine, because in Australia it is definitely a very nice mixture between pre-hospital and retrieval medicine, and we think very strongly that the crossover is valuable to care. But I know that in the UK there was a huge push to separate the two out. What's your view of that now, having kind of seen both perspectives?
Yeah, I mean, it'd be interesting to ask me that question in 10 years' time to see what my job plan will look like. But certainly I think whenever you're training, and for me at this stage, having the breadth of experience across primaries and transfers is really valuable, because they encroach upon each other. When a transfer patient becomes unstable, it gets a little bit like HEM stuff, and certain HEM stuff, as we know, gets a little bit like transfer stuff. So I think having experience across that is important. And as you've alluded to, yep, even from a government sort of commissioning level, unfortunately, in England and Wales, can't remember which year, a few years ago, probably immediately post-COVID, they stipulated that for inter-hospital critical care transfers, the doctor must be either an intensivist or an anaesthetist, and so not an emergency medicine doctor. And they did not put an exemption for pre-hospital trained people, which meant that there was this sort of government Department of Health policy that was saying that emergency medicine doctors can't do any transfers even if they've worked for a HEM service for 10 years. I personally don't think that's the right approach. I think everyone would agree that for the patient, you should have the right care at the right time with the right person or in the right setting. And there are certainly emergency medicine doctors in the UK, in England and Wales who can do that. In Northern Ireland and Scotland, that stipulation hasn't been introduced, and that allowed me to work for the ground-based transfer service, as I alluded to, in Northern Ireland. And that was definitely valuable experience, because as we know in Sydney, dealing with that sort of 50-50 mix of primaries and secondaries, you do take different things away. There's different challenges of those presentations.
Any other questions in the room? I'm just looking, there's some questions from WhatsApp. So if you have any questions, you've got a few minutes to put it into WhatsApp. The only other question I have was, the big challenge in Australia we found was that we're trying to get everyone to kind of standard to the point where we think that they can have a career in pre-hospital retrieval medicine, and the diploma of pre-hospital material medicine, now the associateship, was kind of the idea of how to get them there. But there's such a wide range of systems and services with different capabilities and acuities that the hardest thing was trying to create a system where people working in different systems could all achieve the same level. How do you think that's been handled in the UK?
Yeah, it's a good question. I just wonder if the PHEM services are probably, I just wonder if they're potentially slightly closer aligned across the UK than different pre-hospital providers in Australia and New Zealand. So that's the first thing. In terms of though the approach to how differences have been dealt with, this curriculum, as I mentioned, is on its third version. It has influences from the General Medical Council's sort of training stuff. So that allows it to be completed should be allowed to be completed by everyone. It has taken a very active approach over the last number of years to include not just, as I say, doctors, but also nurses and paramedics working in the pre-hospital sphere. And I think that's very positive. So that's a key thing into it. And then the third thing is the curriculum itself is like free to access, rather than focusing on just one aspect of pre-hospital care. That curriculum looks to address all aspects from extrication to transfer of post-ROS patients, you name it. So the curriculum is, I would say, all encompassing. And so no matter what service you work for, you will cover certain parts of that curriculum, right? But then when it comes to the examinations, the diploma and the fellowship, they're examined at different levels. So for the diploma, as I say, you can definitely train to do it as a standard road paramedic if you push yourself. For the fellowship level, in order to successfully complete that, you need to have worked in a service that can provide you with adequate experience. And so that is only the PHEM training ones and certain other ones that allow you to build a portfolio good enough to get that certificate of eligibility. And then you can complete the exam, and that fellowship exam essentially says that you have covered all of the curriculum at that level. So yeah, hopefully that wasn't too jumbled an answer, but in summary, I think the services are probably more closely aligned than you have across Australia and New Zealand, for example. I think the curriculum just covers everything, and then certain services can do certain bits. So yeah.
Hi, Richard. I'm Scott. I just had a quick question around, the density of services within the UK is quite sort of a magnitude of difference compared to Australia, and your map was pretty indicative of that. Is there a lot of crosstalk between services? And I imagine there are circumstances where you work together on jobs on the borderlines of geographical catchments. And how does that work on a governance perspective with different SOPs and the like?
Yeah, thank you. So from an organizational level, the charity leads, like the non-clinical leaders, have a forum because obviously the charities face similar issues, like fuel costs. At a clinical level, there's also a forum, so all the medical directors have a way to talk to each other in terms of meetings, but also then they, having networked together, they're able to quite literally pick up the phone and talk to each other. And those relationships are obviously stronger with neighbouring groups. Then from a clinical point of view, there's quite a lot of mutual aid. In the southeast here, which is where London is, if London are already engaged in a mission and they have no assets that they can deploy, then Essex will come down, or potentially East Anglia or Kent, Surrey, Sussex will cover the south. If KSS are out somewhere in Kent, and there's something in Surrey, then London will fly out of their catchment zone to cover KSS patients. So, and the way that works on a day-to-day operational level is the HEMS dispatchers for each of those groups will, at least sometimes it's on their software system if the links are really, really close, but otherwise they'll literally phone their equivalent dispatch desk at, say, Hampshire and Isle of Wight and say, do you have an aircraft online today or not? And so the dispatcher in each region will know what mutual aid resources are available should there come a time during that shift when they need to request it. And the other thing that the distribution of HEM services allows is aviation partners to provide contracts with spare aircraft that are available, but then utilized across air ambulances. So you don't necessarily within your aviation contract have to have your own spare aircraft if you're close enough. So for instance, KSS, quite often whenever I was there, flew a yellow aircraft that used to be from Links and Knots, and that 169 is shared as the spare aircraft right across that aviation partner. That doesn't work for everyone. Northern Ireland, as you can see here, is out to one side, and there's a bit of ocean between it and the rest of the UK. So they do have to have their own spare aircraft, and some choose to if they own their own aircraft. So there are a myriad of benefits, I would say, and the whole thing is very constructive and collegiate. It's not competitive in any way, even at a charity level. Although sometimes when people try to do national campaigns for their local charity, that does understandably irritate some of the smaller charities. But for the most part, everyone works really, really well together. And this, I think this is a charity too, Air Ambulances UK. They do quite a lot of work to coordinate that network and that I mentioned, and also improve public awareness of air ambulances' role, not specifically just one or two air ambulances, but just the nature of it. One of the campaigns they did recently, for instance, was explaining to the public that whenever the helicopters can't fly, they can still bring, the skills, the equipment to the patients by car, because as we know, quite a lot of people think it's just getting the patient fast to hospital in a helicopter that's the benefit, and that is an incorrect perception. Hopefully, Scott, does that answer your question?
Thank you. Thanks, Richard. That was really good. Appreciate taking your time on your holiday once again.